This is Dr. Julie Huffmeyer with our Open Anesthesia Intraoperative TEE Case of the Month for July 2011. Each month we will feature an operative case which teaches or emphasizes an important aspect of basic intraoperative TEE. The case presentation this month involves a 64-year-old man with a history of severe mitral regurgitation, moderate tricuspid regurgitation, and dilated cardiomyopathy. He also has a history of chronic atrial fibrillation. His preoperative echocardiogram demonstrated an ejection fraction of 50%. He complains of progressive worsening dyspnea and limited physical activity tolerance, and he presents for repair of both mitral and tricuspid valves. In order to discuss the TEE findings associated with mitral regurgitation, it is important to understand the anatomic relationships of the valves within the heart. This image depicts the bicuspid mitral valve on the lower left, the right-sided tricuspid valve next to it, and the aortic and pulmonic valves. The mitral valve consists of a large anterior leaflet that covers 2/3 of the surface area of the valve, and a smaller posterior leaflet which is C-shaped and wraps around the anterior leaflet, accounting for 2/3 of the circumference of the valve. The anterior leaflet shares the same fibrous attachment as the aortic valve, referred to as the crux of the heart. This area has important implications for surgery on either valve, as misplaced sutures can impair the function of the other valve. Indeed, sutures placed near the anterior mitral valve leaflet may impair closing of the aortic valve. The mitral valve is encircled by a fibromuscular ring, the mitral annulus. This annulus is saddle-shaped and plays an important role in closure of the mitral valve. It is also important to understand that the coaptation between the two leaflets of the mitral valve is not linear. Indeed, that coaptation is C-shaped and must be imaged by TEE in multiple planes so as to obtain a more complete picture of the structure and function of the mitral valve. The mitral valve attaches to two papillary muscles, the anterolateral and posteromedial papillary muscles via chordae tendineae. Each papillary muscle sends off multiple chordae tendineae to both mitral valve leaflets. There are 3 types of chordae. The primary chordae attach to the leaflet edges, the secondary chordae attach to the body of the leaflets, and the tertiary chordae attach to the base of the posterior leaflet only. The chordae tendineae, along with the papillary muscles, have an important role during systole to keep the mitral valve leaflets from prolapsing into the left atrium. The classification of mitral regurgitation is often broken down into 3 types, distinguishable by leaflet motion. Type 1 mitral regurgitation results from annular dilation, and the leaflet motion is considered to be normal. The mitral regurgitation jet will usually be central in location. This is also seen with mitral valve clefts, aneurysms, perforations, or destruction due to endocarditis. Type 2 mitral regurgitation results from excessive leaflet motion such that the jet is usually directed away from the diseased leaflet. There's a spectrum of leaflet motion seen in type 2 mitral regurgitation. Initially, there is a billowing or scalloping motion in which part of the leaflet projects above the level of the annulus in systole, but the coaptation point remains normal or below the level of the annulus. Once leaflet prolapse occurs, there is excursion of the leaflet tip above the level of the annulus in systole, causing mitral regurgitation. With mitral valve flail, the edge of the leaflet flows freely back into the left atrium, most often the result of a ruptured chordae tendineae. Type 3 mitral regurgitation results from restricted leaflet motion, and the mitral regurgitation jet is directed away from the diseased leaflet if only one leaflet is affected. Type 3 mitral regurgitation is further classified into types 3A and 3B. In type 3A, the restriction of leaflets is structural in nature, often due to rheumatic heart disease, and the leaflet motion is affected in both systole and diastole. In type 3B disease, the restriction is functional, and proper coaptation of the leaflets is prevented by systolic tethering of the mitral leaflets due to either a dilated left ventricle or to displaced papillary muscles. Type 3B mitral regurgitation is often referred to as ischemic MR, again most often because it is due to coronary artery disease. The leaflet motion in type 3B disease is normal in diastole and abnormal in systole. Again, with type 3 mitral regurgitation, the jet is usually directed away from the diseased leaflet if only one leaflet is affected. If both leaflets are affected, the jet may be central, which is often what is seen with type 3b disease, as each papillary muscle supports both leaflets. There are multiple echocardiographic methods in which to assess the severity of mitral regurgitation. These TEE images will not focus on those methods specifically, but instead on a few short TEE clips demonstrating mitral regurgitation. Please note that each clip is a single cardiac cycle that is looped repeatedly. This may create the appearance of an arrhythmia. The TEE video has also been slowed significantly for demonstration. This is a mid-esophageal 4-chamber view, usually one of the basic views obtained when the TEE probe is first inserted. It is found in the mid-esophageal location at a multiplane angle of 0 degrees, without anti- or retroflexion of the TEE probe. You can see that both leaflets in this image seem to have excessive leaflet motion as they both prolapse into the left atrium. This patient's mitral valve appears to be myxomatous with excessive tissue. This is the same mid-esophageal 4-chamber view, but this time with color flow Doppler placed across the mitral valve to help get a view of the direction that the blood is flowing. Flow that has a speckled pattern is usually turbulent flow, and that is seen here in the mitral regurgitation that flows backward during systole into the left atrium. You can see that the mitral regurgitation jet appears to be central in location, with a broad neck as it traverses the mitral valve orifice, and it also extends significantly far back into the left atrium as you see the color swirl around. This is the mid-esophageal mitral commissural view at a multiplane angle of about 35 degrees in this patient. The mitral commissural view is often found at a multiplane angle range from 60 to 75 degrees, again at the mid-esophageal depth. This represents another view in which to interrogate the mitral valve for pathology. Different scallops of the anterior and posterior leaflets are seen here, and often there is improved visualization of the papillary muscles and chordae tendineae. Here again you can visualize the excessive leaflet motion of this mitral valve with prolapse of the leaflets and impaired coaptation between the leaflets. Another noteworthy aspect of this TE image is the dilation of the left atrium in this patient. One of the consequences of long-standing mitral regurgitation is that the left atrium becomes dilated due to the increased blood flow into that receiving chamber. This is again the mid-esophageal mitral commissural view with color flow Doppler placed across the mitral valve. It is important again to notice the wide, broad jet of central mitral regurgitation that occurs here and flows back into the left atrium. In summary, the anatomy of the mitral valve and its proximity to other valves within the heart is complex, and this has implications for repair of mitral regurgitation. Mitral regurgitation is classified on the basis of leaflet motion. TEE can quantitatively and qualitatively assess the severity of mitral regurgitation.